As I analyze this plain radiograph of the abdomen and pelvis of an adult patient, the first finding that stands out is the marked thickening of the colon wall, particularly in the mid to distal transverse colon. The appearance of thumbprinting is significant here, which typically suggests submucosal hemorrhage or edema, often seen in conditions such as ischemic colitis or severe inflammatory processes like ulcerative colitis. Additionally, the lack of skip lesions and the continuous nature of the involvement from the mid-transverse colon distally without interruption are suggestive of ulcerative colitis rather than Crohn's disease, which typically shows segmental involvement. There are no signs of bowel perforation, as evidenced by the absence of free intraperitoneal gas under the diaphragm. The cecum and ascending colon appear relatively normal, without significant dilation or gas-filled loops, which is reassuring. The absence of these features reduces the likelihood of complications such as toxic megacolon, which would present with a more severe degree of distension. Given these imaging findings, my primary diagnosis is ulcerative colitis, particularly in an active inflammatory phase, as indicated by the thumbprinting. Crohn's disease is less likely due to the continuous nature of the bowel involvement and the absence of skip lesions. Ischemic colitis is another differential diagnosis to consider, especially in older patients or those with vascular risk factors. But the distribution here suggests a more chronic inflammatory process rather than an acute ischemic event. To further narrow down the diagnosis, I would recommend a contrast-enhanced CT of the abdomen and pelvis, which could provide more detail regarding the extent of bowel wall thickening and help rule out complications such as abscess formation or perforation. Additionally, a colonoscopy with biopsy would be definitive in confirming the diagnosis of ulcerative colitis and assessing the extent and severity of mucosal involvement. In terms of management, if the diagnosis of ulcerative colitis is confirmed, the patient would require medical therapy, starting with aminosalicylates, and possibly escalating to corticosteroids or biologic agents, depending on the severity of the disease. It's crucial to ensure that the patient is stable, with close monitoring for signs of dehydration, electrolyte imbalance, or signs of systemic infection. Immediate consultation with a gastroenterologist would be appropriate for further management, and surgical consultation might be necessary if complications such as toxic megacolon or perforation were suspected.